Good morning. Good morning, everybody. My name is Dr. Khalid bin Thani. I'm going to be the moderator for this session. And this is the third day of the GIS meeting. And I'm going to have with me here in the panel Dr. Abdullah Shihri from Saudi Arabia and Dr. Hassan Al-Tamim from UAE, as well as Saad Kassaf from Saudi Arabia, and Mustafa Shimiri from Saudi Arabia, and Mohammed Shimiri from Kuwait. I would like to start with our first speaker and our first talk. And this session is basically pharmacology for interventional cardiology. So we incorporated this. The reason is to have a touchdown on the latest guidelines, I would say, in the management of post-PCI patient or post-ACS patient. And it's very important for all interventional cardiology to get on hold of the latest guidelines. And I know there will be a lot of questions regarding this. So our first speaker is Dr. Ahmed Alkharaza. He's going to talk about the dual antiplatelet for PCI, short duration versus long duration. He is a consultant interventional cardiologist and head of cardiology department in the Chest Hospital, Kuwait. So I would love to welcome him to the podium here, and let's start.
Thank you. Assalamu alaikum. Good morning, everyone. Thank you for the privilege here to present this talk. So I will present short and long-term DAPT. I don't have any conflict of interest. And the objective is to decide about short versus long-term DAPT in patients who receive PCI. So I start with this presentation. This is an 84-year-old woman, diabetic, frail, has severe COPD, but no previous history of bleeding and no history of AFib, presented with an STEMI, heart failure, severely reduced EF with no significant valvular disease. Her ECG showed high-risk features involving the left main likely, and her labs are within acceptable limit. We measured or assessed her DAPT score and precise score, and is as shown in the slide. This is her coronary angiogram, a diagnostic views. It's a left dominant system, left main involvement, Medina 110. So we said we will stop and discuss with the surgical team. So we spoke with them. She's non-operable, has severe COPD, also regarding her age and limited mobility. So we planned for high-risk PCI with IVUS guidance. So we did the IVUS and the PCI. We optimized the stent. We had an excellent result, provisional stenting. And then we stopped to decide how should we treat her with DAPT. Is it short, less than 6 months? Is it long, more than 12 months? Or should we tailor to the patient? So the background, we know all of us that stent was made to mechanically scaffold the artery to prevent complication from balloon angioplasty, to prevent complication and to maintain patency of the vessel. And nowadays, almost all of us use exclusively drug-eluting stents for coronaries. The use of drug-eluting stents is associated with disadvantages as well, which are delayed re-endothelialization and endothelial dysfunction. And these necessitate the use of extended DAPT. And currently, the standard is 12 months. The short duration is about 6 months, and the long duration about more than 12 months. And the flame of the DAPT was after the initiation of ticlopidine in association with aspirin in the late 90s, that was associated with reduced stent thrombosis and restenosis, and was standardized after CURE trial using aspirin and clopidogrel. We know that the new generation stents associated with reduced early and late stent thrombosis and stenosis, and the use of DAPT could be associated with increased risk of bleeding and reduced ischemic risk. And therefore, there is nowadays a trend toward personalizing the duration of DAPT based on the patient balance of ischemia and bleeding. And we know from the ACC and ESC guidelines that they divide the patient into low risk of ischemic event, stable coronary artery disease. These patients has not been exclusively studied in trials, And we know that they have low risk of ischemia and low risk of subsequent MI. And they divide them also into patients with ACS, high risk of ischemia, and then further divide them into their bleeding risk. And based on that, they assign the duration of DAPT. To help decide the duration of DAPT, there is two main scores: the precise DAPT score, which contains 5 items, all clinical. The score cut point is 25. Less than that is low bleeding risk. Higher than that is high bleeding risk, and is useful for the decision about the bleeding risk of the patients during or at the time of PCI. And after the duration of the DAPT, then you can use the DAPT score, which contains 9 items, clinical and procedural. A score of 2 or more is associated with high ischemic risk and is useful to decide about the duration after 12 months or if the patient has an evidence of bleeding. What is the impact if we actually combine 2 scores together? So this meta-analysis pulled data from 4 different trials and assessed the use of both scores at the same time to decide about short DAPT or long DAPT. And interestingly, they found that there is no difference in the net clinical outcome and the ischemic event between short and the standard DAPT. However, as expected, shorter DAPT will be associated with less bleeding. They came up with this figure saying that patients with high risk of ischemia, when they achieve a DAPT score of 2 and low bleeding risk, less than 25, they should go for the standard therapy, because if you see in the orange section, the incidence of ischemic event is much reduced with the standard therapy, with a significant p-value of 0.02. All the other groups should be applicable for shorter DAPT. Is there a difference between the stent type, polymer-free or polymer-based? And this study was done with Onyx One investigators. Basically, the background of this study, we know the leader-free trial assessed polymer-free versus bare metal stent. Polymer-free was superior. And then ZEOS and senior trials also found that polymer-based is superior to bare metal stent, but there is no head-to-head trial, polymer-free versus polymer-based. They found that there is actually no major difference in the primary outcome, and there is the polymer-based is non-inferior to polymer-free with a significant p-value for non-inferiority. And the same thing was found with regards to the secondary outcome of target lesion failure. They concluded that basically there is no difference, or the polymer-free drug-eluting stent is non-inferior to polymer-based. Polymer-based was non-inferior to polymer-free with regards to safety and efficacy. What about patients with diabetes? This is another meta-analysis of about 8 trials. They pulled data from 38,000 patients. 50% of them went into short DAPT and 50% is standard. What is interesting was 30% were diabetic, and many patients were actually ACS. This is the characteristics of the trials, and this is the result of the trial. What is interesting that the NACE in patients with diabetes was significantly lower with a significant p-value with patients who are treated with short and very short DAPT, 1 to 3 months, compared to patients with non-diabetes. And they also found the same result with regards to MACE. Now, what happened with regard to the major or minor bleeding is basically reduced in overall population if you use a shorter DAPT as expected. They did 2 subgroup analysis, saying whether we should use P2Y12 inhibitors as a monotherapy after the very short DAPT, and they found that there is a significant reduction in incidence of NACE and major bleeding if you substitute P2Y12 inhibitors instead of aspirin as a monotherapy after the very short DAPT, and whether there was any difference between clopidogrel versus ticagrelor, and they found that if you use, whether you use clopidogrel or ticagrelor in the adapted duration, there will be a reduction in NACE and bleeding. But in patient with diabetes, if you substitute ticagrelor for Plavix, you will have a significant reduction in NACE. So the conclusion was patient who receive shorter DAPT will have significant reduction in NACE and MACE in diabetes compared to standard therapy. And in patient with diabetes, we should consider using ticagrelor as part of our adapted duration and ticagrelor as part of our monotherapy after the very short DAPT duration. What about elderly? So this is another meta-analysis of 6 different trials enrolling more than 11,000 patients. About 50% of them were elderly based on their definition above 65. Patients received shorter DAPT defined as less than 6 months and longer DAPT more than 12 months. 40% of the population were ACS and 90% of the population received second-generation drug-eluting stents. This is their primary outcomes and the secondary outcome definition. And this is the frost plot diagram saying that basically in patient above 65, there will be no difference if you use short or long-term DAPT. However, in patient under 65, there is a significant reduction in regards to the primary outcome, especially myocardial infarction, if you use a longer DAPT. And this is the Kaplan-Meier curve that showed an early separation of the curves within the first month if the patients are actually younger, less than 65, as compared to older, more than 65, there is no difference. In the younger patients, there is an absolute risk reduction of 1% if you use a longer duration DAPT. Interestingly, there was a significant reduction there, but the shorter duration of DAPT after PCI in elderly patients, they conclude that this might be beneficial. So always you should consider the patient characteristics and the age, and the younger patient might benefit more from this longer treatment. What is new in the guidelines, in the ACC 2021 guidelines? Really, there is no major difference from the previous guidelines. Especially, the only difference really is if the patient develop a bleed, then you can consider class 2A or 2B for shortening their duration. Back to our case, this is an 84-year-old frail woman, diabetic, admitted with ACS. Culprit was left main, distal left main bifurcation, stented successfully with IVUS guidance. Her score, PCI score is 22, which is low, and DAPT score is 3, which is high. So what would be the duration of DAPT? I will leave that to the audience. And my take-home message here is the duration of DAPT should be tailored to the patient, balance between ischemia and bleeding. And regardless of the stent type, of the second-generation stent type, if the patient is low risk of bleeding and high ischemic risk, standard or long-duration DAPT should be used. Other groups of patients should entertain the idea of shorter DAPT. And if their patient is very high bleeding risk, especially elderly, then abbreviated DAPT could be considered. Thank you.
Thank you, Ahmed, for this lecture. It's great, and great summary, by the way. You made it clearly. If we have any question from the audience, otherwise I'm going to start the questions.
I have one question here.
Okay, go ahead, Dr. Abdullah.
Thank you. It was very comprehensive review. Regarding the people with high risk of bleeding, would you go through a short duration of DAPT versus half dose of P2Y12 inhibitor and give the longer duration? Any comparison between those two approaches?
Thank you for the question. It's a very interesting question. I actually did not find a lot of strong data about this, so I could not suggest the use of low-dose DAPT in patients. I think we should continue with the standard therapy and for the standard duration at the point of time.
Dr. Hassan.
Thank you. Thank you, Dr. Ahmed. Now, most of the meta-analysis really uses clopidogrel. I think very small fraction uses ticagrelor. I think you might have touched on it.
Yep.
Do you think the kind of P2Y12 agent make an impact
Yes.
on your decision?
Yes.
Since we have maybe the Twilight was the only sort of trial that showed that?
Actually, Twilight was strongly positive, and it actually driven a lot of the meta-analysis to use ticagrelor in diabetic patient as a combination of DAPT and ticagrelor as a monotherapy after finishing the DAPT duration. So the Twilight was a strongly positive result and actually changed some of the guideline.
My question to the panel here, it's would the type of the stent determine the duration for your antiplatelet therapy, or it's regardless you're gonna give like a long-term kind of antiplatelet therapy? Start with you, Dr. Hassan.
And I think you touched on it. I think there are multifactorial issues played. I think the stent technology play a major role, the confounding factors in the patient. But I think now everybody uses DS, right?
Yes, so now everybody is using drug-eluting stents. There is really no major difference in the type of stents.
Yeah.
Zion's short trial, the Onyx One trial, the Master DAPT trial, all of them show that you can stop after 1 month or 3 months maximum if you use a new generation medication in patients with high
What do
risk.
you think?
obviously.
I think at the end of the day, it is individualization.
Absolutely.
You depend on your patients and what is his risk, how he, the background history. Then you will decide whether long duration or short duration. But I will guess that a similar patient in your situation, where you have done left main and maybe proximal LAD and proximal circ, I think we will intend to prolong the duration of DAPT for a year if there is no obvious contraindication.
I agree 100% because the other side of that is a catastrophic event. Left main thrombosis is a catastrophic event, so you don't want that to happen.
I see. Okay. Shall we have one question?
Yeah, thank you very much. Nice presentation, nice discussion. My problem is a Twilight. The Twilight is a strong trial, but we should be very careful because it's a low risk to intermediate risk thrombotic trial. So if you analyze the patients in Twilight, they are not a high risk, thrombotic risk and a high bleeding. They are more of a high bleeding and low to moderate risks. So I think that's for me, I'm very careful interpreting Twilight, and I take it that these are not the high thrombotic risk patients. I think that's an important point. What do you think?
Thank you for this suggestion, but as I mentioned in my lecture, I think it is balanced between the risk and benefit. We have all the data, and it is a decision that the clinician has to make, not just the guidelines. The guidelines is to help us decide for the patient, and we should also follow the patient closely if there is a high bleeding risk.
Okay. Thank you, Ahmed. One more question?
One more.
Quick one.
Yeah, I thank you for the great presentation. I have a question to ticagrelor interactions either with other medications or food. What is your experience out of the panelists? I have, for example, patients when they travel somewhere else to Yemen, Palestine, Egypt, they develop minor subcutaneous bleedings. When they come back to UAE, after 1 week, everything is fine. So I don't know, I have the impression there is interactions with food.
Well, can I take that?
Yes.
Okay. I don't think like related to the antiplatelet therapy there is some sort or interactions, I would say, to tell you the truth. To my knowledge, I don't know about the others. Unless if there is other interaction with other medication that the patient is taking, but to the level of having subcutaneous bleeding or bruises, it's more common in the prasugrel patient population than the ticagrelor, patient population. Maybe Antonio has.
No, I think the trials are important, but they exclude many patients. And when you make the decision, you really have to look at the patient in front of you. The lady you presented with the dominant circ, stent implanted, IVUS guided in the left main, has almost zero risk of stent thrombosis. We performed in 95 a study with only aspirin, no terclopidine, with palmar shots, which is a very thick stent, implanted with IVUS guidance, and we had 1.2 incidence of stent thrombosis. So if you implant a stent in the left main, single stent, 4 millimeter or 4.5, with excellent result, you can give aspirin. You don't really need. I know that there is no trials, but with such a big runoff of a dominant circ, it's really theoretical.
Thank you all. I think we
can I
conclude
comment?
here, and thanks, Dr. Ahmed.